improving the way training is done. Sorry, I just got a notification. Thank you. And so during this webinar, I'd like you all to feel free to please place whatever questions you have in the Q&A. And while you're engaging and listening, please also feel free to complete the survey that we put in the Q&A bot. Without any further ado, I would like to welcome our first speaker for this evening. So our first speaker is Professor Vanessa Birch. Professor Vanessa Birch completed her MB-CHB cum laude at the University of Witwatersrand. She then went on to specialize at Groote Hospital and super specialize as a registrar. And super specialized in rheumatology in 2001. In 2007, Prof. Birch received numerous awards for her expertise as a clinician, as well as a clinician teacher, and has received 4 National Lifetime Awards for teaching excellence. And I can attest to some of her teaching prowess, as I was also one of her students in my time at med school. As a clinician, she's had more than 25 years of experience as an internal medicine specialist physician and a rheumatologist, having worked in both district, regional, tertiary, and tertiary teaching hospitals in South Africa. She was the founding head of the Department of Medicine at the busiest acute district general hospital in Cape Town, and she was the first woman ever appointed as chair of medicine in the history of the university. She also served as chief specialist in the acute general medicine service and was the deputy head of the Department of Medicine at Groote Hospital. Professor Birch has played, and she continues to play, a leading role in advancing health professions education in sub-Saharan Africa. And in 2018, Professor Birch became an independent education consultant and provided education and assessment services to the Colleges of Medicine of South Africa, the National Department of Health, as well as the HPCSA. In the year 2020, she was appointed as the Executive Director of Education and Assessment at the Colleges of Medicine in South Africa. And in this position, she has played a critical leadership role in the process of digitalizing all specialist and subspecialist examination procedures conducted by the CMSA. She was also responsible for pioneering the use of online structured oral examinations using Zoom during the COVID-19 pandemic. Professor Vanessa Birch, thank you for gracing us with your presence this evening. We look forward to hearing from you. Over to you.
Thank you, Dr. Harbour, for that very illustrious introduction, and I hope I can do justice to it. I'm going to screen share a short presentation, and really this evening's webinar is to bring the important stakeholders to the table for further dialogue and conversation in the further development of workplace-based assessment for postgraduate training in South Africa. So this evening is going to be an overview, and we're going to have a look at some of the big principles of what we need to do, and then we're going to have a look at where we need to go in terms of where we can go in the future with workplace-based assessment. I just want to open my presentation. Well, let me just get it open on the screen. Give me 1 second. And the important part of this evening's conversation is really that it's an overview for everybody, to get everybody on the same page with where we are with workplace-based assessment, where we're going, and what needs to happen going forward into the future. And this is an important introductory meeting for the stakeholders, who are particularly the trainees. And you will see in the presentation where how much work we've already done, and where you are going to play a really critical role in this process. I'm going to put myself onto a presentation mode, which means I won't be able to see anybody else for the rest of the talk. So essentially, the conversation is really about training for trust, and I think this is a fundamental shift in the whole question about assessment and what assessment means in postgraduate training in South Africa. This talk is not just mine. This talk is really on behalf of a national task team working on workplace-based assessment for postgraduate training in South Africa, mandated by the South African Committee of Medical Deans, as well as the Colleges of Medicine of South Africa. The key issues for this afternoon's conversation essentially are that trust is the foundation for all of clinical training as well as clinical practice, and that is something that we really have not got any qualms about. The second conversation that we want to have this afternoon is about entrustable professional activities, which essentially are units of clinical practice that can be used for building a curriculum and can also be used for building an assessment package, as well as making entrustment decisions about trainees in programs. And the latter part of the presentation is going to be an update on the developments in South Africa. Trust as the foundation for training and practice means trust of 5 things. Firstly, it means trustworthy training, trustworthy trainers, trustworthy trainees, trustworthy assessment, and trustworthy practitioners. And so really the foundation of all of this, including the assessment, which we're going to be talking about this afternoon as a specific focus of our attention, is on the basis of trust. Now, what does trustworthiness in daily clinical work look like? Well, essentially, we have key responsibilities in each of our respective specialties, and we refer to these more latterly as entrustable professional activities. There are practical examples of what you do in the workplace every day, and we call these observable practice activities. Essentially, we can break them down into bite-sized chunks of achievement, and this is what the term milestones refers to. And workplace-based assessment, which is the part of the conversation we're having this afternoon, is about entrustment decisions which are made in real clinical practice. And the final important aspect, which is not going to be much of a focus this afternoon, but is part of the trustworthiness conversation, is the issue of deliberate practice, which is opportunities which are sought specifically for learning in order to become competent. Now, when you describe the product of any training program, and in our case, we are talking about a specialist healthcare practitioner, we describe in terms of 3 outcomes. The first is learning outcomes, what you should have learned. The second issue is who you are, who you have become, and who you should be in the workplace, and we refer to these as competencies. And finally, the issue is the work that you need to be able to do, and we refer to these as entrustable professional activities. So what exactly are entrustable professional activities? Well, they're not new. They've been described and they've been in the ether and in the workplace setting since about 2005. They are growing greatly in global use, and they describe units of professional practice, which is essentially the defined tasks of your daily work as a clinician. These are the tasks which you have been entrusted to deliver as part of safe clinical service. And they are the link between the competencies, which represent who you are, and the tasks, which is what you do. And operationally, they specifically define your specialty or your area of expertise. Clearly, they require specific knowledge, skills, and attributes in order to be able to execute these tasks and activities. And that is what we commonly refer to as a syllabus. It's important that entrustable professional activities can be learned. Otherwise, in fact, you cannot become an expert in them, which means that they have to in some way be observable, teachable, and accessible. They are essentially learned in the workplace in the context of supervised practice, and it is a process of increasing entrustment in the workplace which serves as the foundation for developing competence. So how do EPAs then differ from competencies? Well, what they do is they translate competencies into clinical practice, because essentially competencies describe the person and EPAs describe the work that you need to do. And it's clear that EPAs require multiple competencies which are practiced in an integrated, holistic way in order to deliver clinical service. Just to remind you, when we use the term curriculum, and these are often used interchangeably, the word curriculum and syllabus and activities are often used interchangeably, but in fact, curriculum is the overarching term which not only describes the product of the learning program, which is the practitioner, but includes the syllabus, which often receives a lot of attention, the learning activities, which are increasingly being better defined in portfolios of learning activities for postgraduate training. Importantly, the learning resources which need to be accessed in order to develop competence, and assessment, which is better viewed as a longitudinal process of advancing entrustment rather than snapshot pictures of somebody's competence at specific intervals. And we're going to focus our attention on this particular aspect this afternoon. So if you want to build a curriculum using EPAs, what are you going to do? And this is the work that's being done by the specialist practitioners in South Africa designing postgraduate training programs. Essentially, every specialty has about 40 major responsibilities that describe the scope of practice and for which you have been entrusted to provide independent service. They are defined in terms of time. They have a start and end to all of these tasks. They are recognized by a product or an outcome for the patient, because this is a patient-centered approach to education and training. There may be overlap with other disciplines. For example, the management of an acutely ill patient is common to many of the disciplines and not just one. And as I've said before, they're observable, teachable, and accessible in practice. And they may require many specific examples or index illnesses, which, as I said earlier, are the practical examples of you performing an EPA in the workplace, known as an observable practice activity. Now, what a syllabus does is it describes what you need to know, what you need to be able to do, and the behavior that you should demonstrate in the workplace in order to fulfill the duties of the specialist. Typically, a syllabus should be apportioned to different parts of your training program, and that's where the concept of milestone comes in. And learning experiences are clearly required. Apologies for the spelling error. Learning experiences are clearly required in order for you to be able to become competent in whatever is in the syllabus. And it needs to be clear what is included in the scope of practice of any specific specialty. I don't want to focus too much on learning activities this afternoon, because we really want to talk about workplace-based assessment, but workplace-based learning activities need to be developed in a record. And there are three types of records which will record what you do in the workplace. The one that we are most familiar with is logbooks, which is a record of procedures or tasks or activities performed to gain experience in the workplace. Increasingly, postgraduate training is making use of portfolios of learning, which describe index events or clinical encounters that are used to learn something specific. And internationally, this is a very important aspect of postgraduate training programs in order to be able to verify what training has been undertaken in the international arena. All postgraduates are now required to produce a portfolio of learning activities and tasks undertaken. And more recently, electronic records of entrustment decisions which are made in the workplace. So workplace-based learning activities is not just the entrustment decisions which we talk about typically as workplace-based assessment, but includes the activities that need to be recorded in portfolios of learning and in logbooks, which are already established in postgraduate training. So how do EPAs build into an assessment package? And this is an important concept, that there are two elements to assessment packages in postgraduate training. There is an observation and feedback about your competence in the workplace, which is an authentic lived experience. These are variable experiences, they're real-time experiences, and they occur on the job with the actual patient care that you deliver. And then the ones that we are more familiar with, which is in a supervised assessment setting, which is standardized in examination settings. So in the workplace, what are we going to be looking at in terms of workplace-based assessment, or as I prefer to use the term workplace-based observation with feedback and remediation for what needs to be learned? The first thing that we need to be able to do is capture your professional opinion in the workplace, and I'm going to explain that in a moment. The second thing that we need to be able to see is that you can demonstrate procedural skills proficiency in the workplace. And thirdly, it's important that we observe your professional behavior in the workplace, because all three of those elements need to be present in order to be a competent specialist practitioner. The assessments which you are more familiar with and which traditionally we've been encountering are written assessments of knowledge, which really look at your knowledge base required for safe practice. And those are typically single best answer questions, short answer questions, and the process of digitalization of all of these events, which has taken place very rapidly in the COVID pandemic in the last 3.5 years. And then more recently, structured assessments of decision making, which is how you think on your feet when you're faced with a problem. And we can do these either in written format, which is digital online OSCEs, or we can in fact do them orally on Zoom, which we are calling structured oral examinations. And this is an important assessment because this assessment determines your ability to apply knowledge in practice. But observing you apply knowledge in practice is the domain and the realm really of workplace-based assessment. So what observations are needed in the workplace? In the first instance, I said we needed to be able to observe your professional opinion in practice. And this takes the form of observing patient consultations, reviewing referral letters that you may write as part of your clinical work, pathology reports, radiology reports, hematology reports, a range of reports which are issued by us as the daily part of our work. And for example, in public health, we may even be asking for factory inspection. So it really is how you express your professional opinion, either in a verbal format, in a written format, or in a consultation format in the workplace. second issue is that of procedural skills proficiency. Are you able to do what is required of you in your specialty? And this takes place in a range of places, typically theatres, emergency units, labour wards, outpatient services, radiology suites, the mortuary, and even in the general medical and general pediatric or surgical wards. And the third issue is the issue of professional behaviour. What is your communication like? What are your management skills like? Do you demonstrate empathy and humility when you engage not only with patients and their families, but importantly with staff and colleagues? And what about punctuality and other factors which really broadly describe you as a professional in the workplace? So these are the types or large categories of observations which are needed in the workplace-based assessment suite of observations. Now, the most important shift in workplace-based assessment is a shift from numeric scales 1, 2, 3, 4, 5, which means terrible, okay, good, average, good, really good, excellent, and a range of other words, which are subject to a lot of interpretation, to a shift of entrustment rating scales. And this is a really important part of this afternoon's conversation. When we as clinicians are training staff to become those whom we already are, we really have a pretty simple way of looking at it. You cannot do what is required, and you can only observe because you're still learning. You are able to do the procedure, but under complete supervision, because we may have to intervene at any point in time, be it on a ward round, be it in the theatre, be it in the outpatients, be it in the emergency unit. We're watching you work, and we realize that things are going wrong and we need to step in and intervene. So that is something that you are not yet able to do without supervision. Then we can move to the next level of entrustment, which is where we are able to let you do tasks and activities in the workplace, but you have got on-demand supervision. If you need help, you can call for it and we'll come and we'll support you and assist you, whether that's telephonic support, whether it's in-person support, whether it's video support. It's a range of support options, but you are still not able to perform the entrustable professional activity independently because you're requiring supervision, which may be reactive or on demand. And then you can reach a level of training where you are able to do something independent, and you either get some distant supervision, you may phone a consultant after hours to check that your plan is good or that this is the correct procedure to do. Or in fact, the next morning on the post-intake ward round, you may be discussing with a consultant a patient whom you managed during the night and who has done well overnight, and you are discussing the case really post hoc or after the event. That is the person who is practicing independently and has achieved full entrustment in specialist training terms. And then the final category is really the person who is an advanced trainee and is sufficiently competent to be given the responsibility of training junior staff. You can teach an intern, you can teach a fellow registrar, you can teach a medical officer how to do something, how to assess a patient, how to provide a patient consultation, how to perform a procedure, how to break bad news, or how to write referral letters. So those are the levels of entrustment. And this is really a major and fundamental shift from arbitrary words like not good enough, but not really adequate, but not excellent and excellent, to something which is clearly defined in the world of the clinician, because the core of this entrustment rating scale is patient safety. This is really not about the trainer or about the trainee. This is about providing safe patient care, because the patient is the center of workplace-based assessment processes. Now, entrustment decision-making takes place in two different ways. At the time of the event, which is essentially called an ad hoc entrustment decision, and that is done by the clinician who is observing you in the workplace. And it's not just the clinical supervisors, but other staff in the workplace as well. So, for example, the nurse practitioner may be an ideal person to be able to provide an entrustment decision at the time, or other clinical supervisors in the workplace. These decisions and these activities need to form part of the daily clinical routine. They need to be taking place on ward rounds, taking place in OPD, taking place in theatre, taking place in the emergency unit and in the labour ward. They're not set aside separate from clinical duties. They need to be integrated into clinical duties. They have to be recorded, and we really are looking at digital and smart device related activity methodologies. And the most important part of this activity is feedback, so that you can improve on your current practice. An important part of this is clearly that you require multiple observations by multiple observers at various points in time per year, every year throughout your training. There is a second kind of entrustment decision made, which is at the end of a period of training. So, for example, at the end of a 3 or 4 month rotation, in the outpatients or 3 or 4 months rotation in the emergency unit, the senior clinical management team needs to make decisions about the progress that you have made over the past 3 or 4 months. The information that they use to make these decisions will be based on the entrustment decisions made at the time of events. So the multiple observations from multiple observers will be reviewed at the end of a period of time to make decisions about your overall progress and to institute remediation if you are not achieving milestones. So there is an important difference between entrustment decision-making, which is done on a daily basis in the workplace on ward rounds and OPD, versus the decisions which are made at the end of a period of a rotation of 3 months and uses these multiple events that have been observed in the workplace to make that overarching, overall, big picture decision about the progress that you've made in 3 months. Now, just to give you an idea about how much work has been going on in this field already, and there will be many questions in the after the presentation this afternoon about the specifics of workplace-based assessment, and I'd like to refer you to 3 recent publications which we've written on the topic, and this includes the members of the national task team representing all the universities in South Africa who undertake postgraduate training in the different specialties. We've been hard at work at doing quite a lot of research in South Africa so that we can come to a decision about the feasibility, sustainability, and practicability of workplace-based assessment in South Africa. This is not a decision taken from the global north and implemented in the global south with any amount of thought put into it. This is a very useful paper which I wrote just before the pandemic about the workplace-based assessment. It provides a very broad overview. It answers questions like, should there be many observers? Do you need a lot of observations? What are different instruments using for observation? These are all the detailed kinds of questions typically that may come up in the conversation this afternoon, and I'm going to refer people to this work, which is really very useful and gives you a broad brushstroke overview of all of those issues. The second work that I'd like to refer you to is to show you that we are very actively working on pilot studies and development projects in South Africa in the different disciplines. This is an example coming from surgery in South Africa, looking at workplace-based assessment as a new era of surgical training competency in South Africa. And there is another paper written by the same group of authors where we asked stakeholders, registrars and consultants, were interviewed and asked in great detail what they felt was needed in the workplace. And the unanimous opinion from that piece of research work was that workplace-based assessment is really the way to go. It's the place to see you in action, and we can get multiple observations of you in the workplace. And so these 2 papers in tandem have recently been published looking at specifically advances in the development of surgery workplace-based assessment. And the final paper is an important paper. It was published just 2 weeks ago. And this is an interview paper again where we've done qualitative research asking the question from supervisors about the feasibility of introducing workplace-based assessment for medical specialist training in South Africa. This is a broad paper from several centers in South Africa. And the truth is that we have resource challenges. But I would advise that people read this paper. I would encourage you to go and read this paper, and we'll put the links in the chat at the end of this presentation, where you can go and have a look at a reality check of what are the barriers to implementation, what are the factors that will support implementation, and where are we going to navigate this space in South Africa. So there are some important pieces of work that are emerging in the literature, and this is international literature on this topic for South Africa. And the important part of this evening's conversation is that to bring additional stakeholders now to the important part of the conversation, which is actually the design and implementation of workplace-based assessment as it goes forward. And I'm going to stop my share now, because I really want to just talk very briefly to where we are. We have a national task team, and we're going to get an update from Professor Green-Thompson on the work of that national task team. And really, the stakeholder engagement at this stage has been looking at issues of feasibility, about the technical capabilities, about digital platform uses, what digital platforms may work. And we've now launched a phase, and many of you will have heard about this and may be becoming involved in this, where we are launching pilot studies to look at the implementation of specific workplace-based assessment tools in the workplace, in departments around the country, at university sites. We're aiming to involve departments in all the universities in these pop-up pilot studies, because we know that the playing field is not level, that the resources at the different training institutions are quite different, and we need to keep that in mind with the rollout and implementation. And the trainees, the registrars, are being onboarded in all of these important proper pilot studies. There's an important onboarding process for all of them. And this is part of the wider stakeholder engagement conversation this evening, which we're very excited to be having with you as an audience. And I'd like to hand over now to, I think what we'll do is we'll probably keep our chat questions to the end. And I'd like to invite Professor Green-Thompson to provide us with an update on the workplace-based assessment working group in South Africa and the progress that we've made over the last 18 months. Thank you very much.
Good evening, colleagues, and thanks very much for this opportunity to talk to you from the point of view of the WBA Steering Committee nationally. I think that what Vanessa's done very well for us is just craft the landscape both nationally and then as it's being translated on a daily basis into the South African context. I don't have a presentation because my thoughts are really just the steps that we've taken so far as that WBA that WBA Steering Committee nationally. And perhaps even at this stage, I want to be as bold as to say that perhaps at the end of it, I think it was the doctor at the beginning spoke about being the chair of the Registrars Association. It might well be an occasion to actually talk about how we get registrars represented on the various structures that have been engaged in the process thus far. Let me just make a couple of points that we come from the Committee of Medical Deans. I'm currently the chair of the Committee of Medical Deans. In fact, I'm at my last meeting. Next year it will be somebody else. But I think the key thing that we've engaged in the reflection on WBA is this idea of authenticity. We've had a significant journey from those really high stakes exams. Just to give you an example, when I wrote the college exams, you could be asked a question which went something like this: discuss the perioperative management of hypothyroidism. And so for your 100 marks, you could go in any direction altogether. I'm still not sure what they thought I knew at the end of that. But I think it's also recognizing the fact that to get reliable clinical exams as a high stakes exit point, you require multiple cases and multiple exposures in much the same way as you see the movement to the online OSCEs currently. But I think you heard Professor Birch speak about that scale of entrustability, the scale from where I can't leave this doctor to do anything. And I think it applies to interns as well. To this person is really functioning at a level that I know that they will call me when they need me. And so what that does, what that entrustment assessment does, what that entrustment evaluation does, is it shifts the assessment of clinical practice from the opinion of the examiner to the feeling of level of trust that the examiner holds for the conduct of a particular activity. And this idea of trust is something that's recurrent. So it also, when one thinks about the self-evaluation process, that entrustment, you can use it as a self-evaluation tool because you yourself know then, this is an EPA, it's an entrustable professional activity. You can make a call for your own practice of where you are on that continuum. But I just want to give a summary today of the steps that have happened over the last now 2 years that we've been working on the WBA process. We started off setting up a joint committee that, as Professor Birch says, was mandated by the Committee of Medical Deans and the Colleges of Medicine of South Africa. So what we ensured is that in the steering committee, every single university that trains specialists in South Africa had 2 members on that group, partly so that we could ensure continuity, but really so that we ensured we didn't leave anybody behind in the process. On that steering committee were Professor Birch and Professor Boch from the Colleges of Medicine. The remainder of people were representatives from the university. And part of the idea is that this committee came into being after we had conducted a series of roadshows before that, just informing the training public, so to speak. And so there were open series of roadshows. And by the time we finished 3 or 4 of them, we'd had in excess of 1,000 people having been in those rooms, all with very enthusiastic responses. In addition to those, we were able to showcase in those road shows where people were testing out in this kind of process already, number of surgical disciplines across the space. We made a commitment to developing what we called EPA 101. We wanted to ensure that we built the base of knowledge, the critical mass of people across the country who didn't jump onto the bandwagon as a fad, but were substantially trained in the process. So many of us joined a course out of the Netherlands run by Ollie ten Kart, and I think in the country now there must be in excess of 30 people who were trained on that original course. We then translated it into a course. In fact, Professor Birch did the majority of the work in that area. And what we've done then subsequent to that is every single specialist training platform has had one of these EPA 101 sessions to train the teachers of registrars in all of those areas. And the enthusiasm has been palpable. I did the 3 workshops. I went to Walter Sisulu on my own because the team ended up not being available that weekend. I joined the session at Nelson Mandela University, as you know, is coming on board. They don't have trainees yet. And I also joined the one at Polokwane. And I think Professor Birch attended together with Professor Adam all of the remaining sites across the town, across the country. I think that the question of longitudinality really can't be emphasized enough, because really what it's saying is that all too often, and I think it will serve 2 purposes. It will help an early reflection for the registrar and their trainer about whether the registrar has found the appropriate specialty. At the moment, many students stay in the process for a long time and really then struggle with the exam at the exit point because they really haven't quite fit into the discipline that they've chosen. So essentially what this process does is that it combines the assessment of your cognitive knowledge, your psychomotor knowledge, as well as your affective knowledge, and that capacity rather than knowledge. And so that's the point that Professor Birch is making about the fact that for the first time we can foreground the assessment of behaviors and professionalism, professional conduct in the environment of learning. Where we are now is about looking at the ideas of creating pop-ups across the country. So the PhD that Professor Birch is referring to has been instrumental in crafting a kind of test-worthy electronic platform. Of course, much more work needs to be engaged if we're going to scale that up across the country, and that remains our commitment, is that we develop a common electronic platform that will cover the whole country. And then also, it's the first time nationally that universities are actually going to sit together and take responsibility for the clinical assessment of their students as registrars through the process. So that's a really important advance, that we build this consortium of specialist assessment, essentially, that will cover all of the registrars' processes along the way. And I suppose my concluding remark then is really to say, this is the first of our engagements, or my certainly conversation with registrars and members of the trainee population. We've spoken in pockets to many people, but perhaps the conversation has to begin about how we get registrars represented on the various structures that are currently engaging in the conversation nationally. Thank you very much, Dr. Hala. I think Dr. Birch, Prof. Birch, Professor Brook might make some comments now, sorry.
No problem. Thank you so much, Professor Green Thompson. I will now like to hand over to Prof. Buch, if you're online. Just a quick couple of words.
Yes, I am. I've been online the whole time. I'm just going to make a couple of comments because I think we should move to the Q&A. Cool. So I think the important thing here is that the model, both of training and of assessment, is evolving. So that workplace-based assessment brings us in line in the country with international best practice and advances both the quality and confidence of the specialists we're training, as well as the quality of the assessment as a specialist. So basically, the important thing is, if you're going to be an ophthalmologist, just for example, I suppose because I'm looking at my spectacles when I'm speaking, then the question is, when someone graduates as an ophthalmologist and registers with the HPCSA as a specialist in ophthalmology, what should they be able to be trusted to do? And then what you do is you define those, what we call entrustable professional activities, and you say a newly qualified ophthalmologist, we should be able to trust, they should be able to trust themselves, and the public should be able to trust them to be able to do the following. It may be certain surgery, it may be certain assessments, it may be certain other procedures, et cetera, et cetera. And what we're saying is it's not good enough to get to the end of 4 years and then say, yes, you've made it or you haven't made it at that sudden point in time. And part of it may be to break down what should an ophthalmology registrar have achieved by the end of first year, second year, third year, fourth year. And that is in the workplace. You can't have a final exam around a patient's bedside or over a computer at the end of 4 years and decide whether an ophthalmologist is competent to do cataract surgery or surgery for retinal detachment at the bedside or over a computer. So the whole idea here is to give clear benchmarks to registrars and their supervisors of what they should be achieving. Registrars are then also able to engage with their supervisors and say, but I need to build these skills and competences and direct their learning. And then the important thing is when it comes to exams and assessment, we are moving towards a 3-phase process. The first step will be assessment of clinical competence, which includes surgical competence and other competences such as reading X-rays and other radiological information relevant to your discipline and so on. So there is assessment of clinical competence through workplace-based assessment, assessment of knowledge through written exams. And as Vanessa said, that is now moved from long essays and things like that to a much better format of single best answer questions. So we don't try and trick people with MCQs, single best answer questions and short answer questions. And then the third step is to assess clinical reasoning, clinical judgment, clinical decision-making through structured oral exams that are there. While we're working towards workplace-based assessment, we still sometimes have local clinical exams with a national examiner in disciplines like for physicians and pediatricians, but those local clinical exams will disappear when workplace-based assessment kicks in. So in short, workplace-based assessment is in a way revolutionary in advancing the quality of learning of registrars over the 4 years because it shifts the learning into a much more structured program of supervised learning towards these entrustable professional activities. What should we be able to trust a newly qualified pediatrician, a newly qualified chemical pathologist to be able to do successfully, number one, and number two, how do we assess that they are capable of it? And that's through the workplace by the university. So the universities will assess competence for workplace-based assessment for clinical competence. And then once that's achieved, the CMSA will take over and assess knowledge and clinical reasoning, decision-making, and judgment. So that's how the process will evolve. I think I'll stop there. I think certainly I am, and Vanessa and Lionel are the national experts in the field, and they're ready to take questions as well. I don't know, Dr. Hooper, if you're going to pick up the questions from the Q&A and then pose them so that everyone knows them, and then the panel can answer. Thanks.
Thank you so much, Prof. I think the plan will be for me to read out the questions, and then the panel can perhaps decide on who wants to answer any of the questions. So perhaps I'll give the registrars just a few more minutes to enter a few more questions, and then maybe I'll use this opportunity to ask my own question, if that's okay. And maybe while I have the floor, just to make registrars aware that there is a link in the Q&A where they can complete a survey. So my first question is, I think it's important, I see the benefit of work-based assessment in terms of now registrars aren't only given the opportunity at one exam to prove themselves. I think Prof. Birch was talking about how, you have the snapshot and you're no longer moving to that one day where you're hoping that you're at your best, but you've been trained and you've been assessed numerous times to make sure that you are where you're supposed to be. So I see the benefit there. But my concern, and I think some concerns of other registrars, is in certain disciplines or maybe universities where there might be an issue of discrimination. Is there a way to perhaps mitigate against that? So, if someone isn't willing to teach you. So people were saying that, previously they may prefer to take their chances with the CMSA because at the CMSA, they're just a number, whereas they may have offended someone in the university that they're coming from. So is there a way to maybe even, let's say, enhance trust during this process to make sure that things like discrimination can be prevented? Anyone is welcome to answer that.
Shall I give a first stab at that? I think that's such an important question, Dr. Harbour, because in many ways, those are the subjectivities of the spaces that we work in. And part of the idea is that no person can rise and fall on a single encounter. And that's the really, really important thing. There is no way in a system where you're assessed over a year, for instance, that nobody is going to ask why you haven't been thrown off the program if somebody has found you untrustworthy in every single assessment. So part of the thing is that one of the things that we're increasingly valuing in assessment these days is that part of the thing that makes an assessment more reliable, whether it's one individual that you're not getting on with, it's unlikely to be the single assessment that prevails if there are even three people in a department. That because the concern is that I've had an argument with so-and-so, I disagreed with them on a specific thing, and now they're targeting me. Unless every one of the people in the department is behaving in that way, a single individual's opinion will not be able to prevail. So the really key thing here is that there are a number of assessments over a period of time. And so even that bias that may creep into our interpersonal relationships, it's diluted or it's mitigated by the fact that reliability over the period is improved. I mean, I think there's some disciplines also asking the question where in fact there are only one or two specialists in their unit. And that's something we're going to have to grapple with as the system rolls out. I think those risks are less than if you just bank on a single event somewhere else. Thanks, Dr. Harbour.
Thank you so much, Prof. Would anyone else like to take a stab at that, or shall I move?
I'm happy to add
to the Q&A questions.
Yeah, I'm Sharon. I'm happy to add some. It's nice to see you, by the way. It's an important question, and I think that the issue really revolves around the small disciplines with few numbers of consultants in a particular training unit, and these are the issues that we have on the table that we need to grapple with. They fall really under the issue of resources, Clearly, limited resources can result in bias, and that's the question you're asking. But these are the issues that are on the table for conversation and discussion as we go forward in this, because the issue is in some disciplines, there really are very few specialists in training programs as consultants, and we're going to have to share these resources around the country so that people have the opportunity for multiple observations. And those observations may in fact be digital, and we are using increasingly the digital space in order to be able to have conversations with trainees and make assessments of trainees. And that's why I think the digital space revolution for assessment is a really important space to work in, because it opens up all sorts of opportunities. During the COVID pandemic, for example, we were able to provide assessments using tablets and remote examiners. And that's an ongoing practice even now post-pandemic because of the efficiency of the system. But we need to become creative about expanding the opportunities for tablet-based digital assessment remotely by people from other units and other centers where there's small numbers of assessors in units that are in small specialties and training centers. I think that's an important issue that we're looking at.
Okay, thank you. I think it's good to know that it's also something you guys are aware of and you're looking at. The first question is from Catherine Dold. She said, good evening. She represents the Ophthalmology Society's Young Ophthalmologist, and she'd like to be in contact with a representative from Sarah and have a voice at the meetings. All right, so I think we will get someone online, either Rena or Dr. Zianda, I think maybe can contact Catherine. And then her question to the panel was, when can we expect the format of the CMSA work-based assessments to start changing? So perhaps Prof. Green-Thompson can maybe take that. So the question, I repeat, is when can they expect the format of the CMSA work-based assessments to start changing or perhaps to be implemented?
So I think so two things. The one is that I believe sooner rather than later, at a very basic level, because I think once we can open this playing field, I think the standard will improve. Our commitment at the moment, so Professor Birch is supervising a PhD, which is looking at implementation in surgery particularly. I know that ENT has already written EPAs, family medicine has already written EPAs. Our aim, Dr. Harbour, and I forget the questioner's name, our intention was that we get the first disciplines ready to roll as early as 2025, and that we would then do a phased roll out across all of the disciplines. Currently, we have got pop-ups planned over the next 6 to 8 months across a range of disciplines nationally. And all of those are being done in conjunction with the college councils, as well as the various universities. So some disciplines are going to test in a single university. Others, like family medicine, are ready to test across a range of sites. So the commitment now is to translate what we've been thinking into a practical implementation plan with a couple of tests so that we can tease out. And each of those tests will have registrar feedback and consultant feedback, because remember, there's going to be a learning process for both people, a kind of change management process for both the registrars as well as the teachers on the platform, because we're giving the teachers quite a significant responsibility in the system. Thanks, Dr. Harbour. I think Vanessa wants to add to that.
No, I think that's an adequate answer. Thank you, Lionel.
Okay, Lionel, Vanessa's endorsed your answer as adequate, but maybe I can just add one little thing, is to say, in short, 2024 is pilots, and 2025, the aim is to be implementing in 2025. And that what we're saying is that in some, for some registrars who are along the way, so we hope that first-year registrars will start in 2025, but we also hope that second and third-year registrars will be able to start the process even though it's halfway along their training.
Dr. Harbour, can I address the question? Oh gosh, now I've lost it.
Prof. Green Thompson, was this
the chat?
Mm-hmm.
Sorry, Dr. Harbour, there's a question in the chat which I do think needs to be dealt with here. And unfortunately, I can't see it anymore. It's just before this Shelley McGee one. Can you see it? Somebody was asking about the role of
Is it? Yes, I see it. With the proposed, I can read it to you. I see it. It says, with the proposed dual route to specialization in the pipeline, will the WBA only become applicable to those affiliated to the CMSA, or should it be formalized? So I'll repeat it, that with the proposed dual route to specialization coming up, will WBA only be applicable to those people who are affiliated to the CMSA, or will it be applicable to both, I think?
So let me be very clear. At this stage, the Committee of Medical Deans is committed to a single unitary exam. So there's no two groups of people. If the HPCSA, and we are continually expressing our opinion to them, because what the unitary exam does for us in South Africa is it broadens the idea that there's a single accrediting or qualifying body in the country. In the same way that if you look at surgery in East Africa, there are a series of countries who offer one exam for the qualification of surgeons in the east of Africa. Similarly, in West Africa, there's a single body that assesses the specialists for that region. That's part of the justification for a unitary exam. There's a process that the HPCSA is engaging with. Whatever decision they make, we will have to engage with it as all universities. And therefore, we really have represented quite strongly to the HPCSA that all of us who assess believe that both for quality and the safety of examinees that was being asked about earlier, a single unitary exam guarantees us a greater sense of quality and authenticity. Because I think that is a thing that troubles registrars every now and again. Thanks, Dr. Harbour.
Yes, thank you so much. I think, yes, it has been something that we've engaged with as well in terms of the dual route to specialization and what registrars seem to feel or seem to think about it. But I guess we'll wait for the HPCSA and we'll see if anything changes. All right, on to the next question. The next is from Shelley McGee. Good evening. Thanks for setting up a meeting for such a topic. I believe WBA can only have a positive impact on the competency of candidates. I am the operations head of an association for one of the specialist disciplines. Can you advise at this stage what has been mandated by the Committee of Deans and College? Has anything yet been mandated in terms of the training? Some of our registrars in ophthalmology say they've already done some WBAs, but as you described what is envisioned, this is an ongoing process, not an event. I think this has already been addressed in terms of the fact that it hasn't been rolled out yet. What Prof was saying initially was that they're hoping to roll out the first discipline in 2025, and from then roll out other disciplines in a graduated process. Okay, Prof Birch, I see you. I think perhaps you can add.
Thanks, Sharon. I think the issue is that for forever, including when I was a trainee as a registrar, workplace-based assessment was taking place. We were often given an opinion about what we were doing, what we could do better, what we did well, and what we could do to learn further. So workplace-based assessment is not new. It's been part of our training process, and I believe that it's been the training process of clinicians ever since the beginning of the time of medicine. Because we walk alongside you and we watch out for patient safety, and we won't let you do things which is going to cause patient harm. If we can prevent it, then we help you and we train you. So the issue, or the fact that's changed, what has changed is the need to record it properly so that we can use it to make bigger decisions about you. So that we've been doing it for a very long time is clear. That we've been recording it adequately is not clear. And I think this move is really a move to getting a digital footprint of the trainee in the workplace. And I think that's really what it is. It's, can we get a digital footprint established of you in the workplace so that we can give you an opinion which is based on many people's opinions about how you're doing and where you are. And I think that's the important issue. So we're moving towards it. In many of the disciplines, people have been doing different types of workplace-based assessment. It hasn't necessarily been called that. It's been called registrars in training, registrar observations in training, registrar assessment in training. It's been given a range of different names. We're trying to standardize the terminology and really just formalize the process so that the playing field is level across all institutions. Everybody knows what's going on and everybody has some kind of record of it. And I think that's really the emphasis now, is capturing the opinions in the workplace so that people have them as a record of progress in training, or the need to improve in training, or the need to develop an additional skill. And I think that's really the issue. So registrars in different disciplines may say, but you know, I'm often assessed on a ward round, or I often get asked in a clinic and I get an assessment in a clinic. This in fact is happening in some institutions, and so there are varying levels of implementation of assessment in the workplace at different institutions. What we want to try and achieve with this process is that we can try and achieve some rollout across the country in all disciplines at a minimum level, and then build on that. Some people may have more resources, they may be doing more. Some people have less resources, they may be doing the minimum requirements. So it's really a process of formalizing it, digitalizing it, and capturing it in the cloud so that we can actually use it to make decisions in a more objective way. I think that answers your question.
Thank you. And I think for me, when I think about it, also the potential strength as well is the fact that you're able to identify early. I think, as Prof. Green Thompson was saying, is that perhaps in your first year, you can already see what your deficiencies are. I don't think that a candidate should be finding out what their deficiencies are in their fourth year, for example. And then you're given the opportunity to improve earlier on. So that is, I think, for me, one of the biggest potential strengths. And secondly, the fact that everyone is clear on what is required, right? So if someone says what is good to Sharon and what's good to Prof. Buch are different. But if I know that Prof. Buch doesn't need to be in the theater room when I'm operating, and we both agree on that's good enough, I think then we agree that, you know, I'm competent. And once we have, I think, clarity from both the teachers as well as those that are trained, I think then we can have maybe a bit more trust, because it means the same for all of us. Prof. Buch, your hand was up.
Yes, thanks very much. I mean, I think, yes, we have been doing workplace-based assessment since I was a registrar, which was before Vanessa was a registrar. But there is a huge difference, and that is that before it was kind of a very informal sort of process. Now it's going to really enhance registrar learning, because it's much more structured. It's much clearer about what you need to be competent in across all the areas. And therefore, it'll enhance registrars' learning, because it's clearer what you need to cover. And it's also clearer in terms of the feedback that you're getting and the support and learning you're getting across the 4 years. And then the other big change is that it becomes a part of your assessment. So in a way, it's a 3-phase assessment. You declared clinically competent, knowledge competent, and clinical reasoning, judgment, and decision-making competent. And therefore, overall, it enhances registrar learning. It lifts registrar learning to a higher level. And therefore, we expect to get specialists that are actually better than their predecessors at the time they qualify, and also specialists that are more likely to pass the exams, because of the strength of workplace-based assessment in preparing them. So we think it'll also contribute to not just better assessment, but better pass rates.
Thank you so much, Prof. The next question is from Dr.
Can I make
Dawood.
a comment?
Oh, yeah, go for
sorry,
it.
I should have used the hand for, I thought showing my face might indicate that I'll speak, but sorry about that. I just want to deal with a couple of the questions in the chat, Dr. Harbour. The one by Shelley McGee. I want to say that people are going to start encountering these WBAs in the EPA type processes in the various workplaces, because I think some disciplines are ahead of others in terms of that. So they're going to be people experimenting with with what they've got. Ophthalmology, I'm aware, has done a fair amount of work. ENT, family medicine has probably done the most work that I know. And then the idea, how soon will the exit exam be replaced? Our view is as soon as possible. But what we really have to engage in is to make sure that everybody's prepared. We're recognizing this as a change management process, and we're recognizing that moving too quickly in one area and too slowly in another, for me tonight has been excellent in terms of speaking to a stakeholder that cannot be left out of the conversation. We've done the preparatory work. Now we're able to say it's time to talk to the registrars and expand the breadth of what we're doing. So that's just an answer to some of the questions. Thanks.
Thank you, Prof. I'll now be going on to the next question by Dr. Dawood. And the question is, how soon will the exit clinical examination be replaced by WBAs?
Yeah, thanks, Sharon. That's just the question I wanted to address. I think we must be clear that the capstone examination, which is looking at theoretical knowledge and clinical decision-making, will remain in place. What we're looking at doing is that this end of training clinical examination, the bedside clinical examination, which many specialties have had, is going to be replaced by workplace-based assessment. So the decision about your clinical competence in the workplace will be replaced by workplace-based assessment. The decision about your theoretical knowledge base and your ability to use that knowledge base to make good clinical decisions will remain as a capstone or end of training examination process. But we are looking at already, we have been phasing out the end of training clinical assessment of competence from the examination as it was face-to-face and centralized in the past. During the COVID pandemic, we decentralized that for the clinical disciplines, for example, pediatrics, physicians, psychiatry, being a decentralized process. We're aiming to continue that and integrate that into assessment in the workplace in the process of 2024 and 2025. So there are transitions already in place for the clinical examination of the competence, but the capstone assessment of theoretical knowledge and your ability to use that knowledge to make good clinical decisions will remain in place as it currently is. And we've been working on the digitalization of that and enhancing the quality of those exams, increasing the standardization and the fairness. Thanks, Maria.
Thank you. So just to confirm, does this mean that instead of the written and the practical, that practical aspect will fall away?
That's the intention. So the written component will remain. The oral examination, the structured oral examination currently conducted on Zoom is the intention that is your ability to think on your feet and make good clinical decisions using your knowledge base. That will remain. And it's this practical component of can you use a patella ham and do you know how to examine the cardiovascular system? That's going to become an in-training process.
Cool. Thank you. Next question is by Dr. Dix. He thanks everyone for the talks. He has two questions. The first is whether or not there's currently a timeline for implementation of work-based assessment. And I think that has been addressed. And then the second is, do you think work-based assessment will take time away from busy centers who are already overwhelmed by clinical service delivery? I see Prof. Green Thompson has his hand up. Please go ahead.
Yeah, I wanted to address that. I think you're right about having answered the question about implementation. We'll keep working at this. I think this question about the service delivery platform is a significant one. My sense is that what will probably happen is that one of it is, and that's what the pop-ups are for, isn't it? It's about saying, in the encounter of the registrar with the system, what is the response and how does it need to be adapted? Similarly, those pop-ups will tell us what the staff feel. Is it taking more time? What we've envisaged, and certainly in the models that I've seen people present of what's possible, it shouldn't add much time to the service platform at all. So the way I'm thinking about it in anesthesia, for instance, because I'm an anesthesiologist by training, this is the kind of thing that at the end of a preoperative evaluation, because I'm not sure if you're aware that in the evening, before a list is done, a registrar will call their consultant and say, this is what I found on the patient, a whole long story. That at the end of that could be a reflection on an EPA. you know? And sometimes if I can just think about my own practice, what could be trustworthy there would be to say, I'm not sure. I have to check what they said in the morning. That puts a person at a 3 or a 2, right? But I don't have to do any more. I can put a voice note into the assessment platform. And then in the morning, I can say, actually, this was a really good assessment. Actually, this is a 4 or 5. And so it becomes part of our daily practice that we're constantly evaluating what our trainees are doing, rather than them going weeks before we give them a reflection that the work that they were doing was trustworthy or not. So I think that's a really, really important point, and we'll test it. We'll test it, and we'll modify it so that the impacts on the service, we don't want the world to stop for the assessment to happen, because none of us can afford that. You know, we don't have to shout that this is the hour for EPA. It must become a part of the regular organic work process that we're doing. Because we reckon that patient safety is the purpose of why we assess in the first place. And if we can't be safe in a busy space, well, let's work out how best to do it. Thanks.
Thank you so much, Prof. Would anyone else like to chime in on that? Can I go ahead? Okay.
Yeah, maybe just to add that, as I understand it, we would also envisage that every so often, once a quarter, every 6 months, and in a much more structured way at the end of a year, there should be time for a registrar to sit down with the head of department or with the head of registrar training and to take stock overall and say, how's the year gone? What are the key areas that you as a registrar feel need to be focused on, and how will you get that learning in the next year? What is the department see as key areas for your development? So it becomes like a partnership. That may take some time, but theoretically, heads of departments or senior consultants or the person in charge of the registrar should be meeting with registrars on a regular basis to take stock overall rather than on individual assessments. So if that's not being done, it may take some time out, but the advantage is it's such a critical thing that it should be done. And if WBA encourages that, that's also great for our registrars.
Thank you. So the next question is by Dr. Mate. My question is to the panel. Knowing that readiness to write exams does not equal competence, how do we position WBA or EPA assessments in view of college exams, as registrars are deemed to be competent when they sit for exams, which is currently not the case? So should EPAs be used to sign off the writing of exams? Perhaps Prof. Birch can help us with that.
I think this is going to be a joint answer from the Committee of Medical Deans as well, because ultimately training programs are signed off by the universities and the examination is hosted by the college. But I think the answer is that, yes, people should be signed off before they go to the examinations, and they should be deemed competent before they go to the examinations, because that really is the way in which clinical training works. You need to be clinically competent, and you need to have a knowledge base, and you need to be able to think on your feet. So I think that would be the sequence that would make the most sense. And we're in the process of working out exactly how that's going to translate into practical implementation at this stage. These are all the processes that are part of the work for 2024.
Thank you.
Yeah, if I can just add to that, Dr. Hava, I mean, I think that's a really useful question. And for me, if the process of shifting the way we assess helps, so what I'm hearing in Dr. Martin's question is quite a rich education question, because what we've come to accept as standard for competence in clinical work is the exam. If you pass the exam and perform well on the day, you're okay. What we're doing is shifting the table a little bit to say, actually, we watched you for a while, because every entrustable professional activity that you needed to show to demonstrate competency in or demonstrate trustworthiness in has got a knowledge component, it's got a skills component, and it's got a professional attitudes component. So if we think that you've matched all the milestones on the EPA's year on year on year, what we are saying is that we can trust you to be a good clinical specialist. The exam then tests, do you really have the breadth of knowledge that's required? And can you work on your feet? One of the things in the workshop that we did from the group at Utrecht in the Netherlands, there's a section called the what if question. What if this case was different? You know, what if I did this cesarean in a normal routine way and I demonstrate the EPA? One of the capacities I've got to show trustworthiness is that if suddenly the belly fills up with blood, what happens? You know, that's not something we're going to predict every student will see together with the supervisor. And so that's a very mature education question. Do exams tell us about competency? Does competency tell us whether we can trust this candidate or not? And we're hoping that as we evolve in this process, we grow into a place where these things work in a complete harmony in a continuum to the exam process as a capstone event, and then exiting as competent and trustworthy clinicians. Thanks.
Thank you, Prof. Green-Thompson. We have our next question by Dr. Sello. Good evening, everyone. Thank you for a presentation laden with wisdom. And the question is, are we going to carry least resource institutions to bring them on par with the dictates of WBA? I'll just repeat that. Are we going to carry least resourced institutions to bring them on par with the dictates of WBA? So my understanding was, you know, with regards to work-based assessment, that every university was going to be engaged and every university was going to have an input. And so I think even from the smallest universities with one specialist to your big universities, I think everyone should be represented. But I'll hand it over if there's anything the panelists want to add.
I just want to say that I thought you answered that very well. That's exactly the principle, is that no one left behind. And if we have to share the resources across the system, we will have to do that. Already we've done the training workshops. Professor Birch and the team have done every single university. That's unprecedented in South Africa, that a team goes to every single university to train with them, to create with them, and to validate the processes that they're engaged in.
Yeah, and if I may add to that, just to say that at the CMSA, we are very concerned about transformation and equity, and we have also now established a health policy committee in the CMSA that's going to get going. And amongst those, we are committed to advocating for fairness and equity in the training platforms. So we've already discussed with the Minister of Health that, for example, the training institutions, Walter Sisulu and Nelson Mandela University, need their academic hospitals and the number of specialist posts and so on to be increased to be able to enhance the quality of registrar training and the opportunities for registrars there. So I think we are at one on that, and we will continue to advocate for that. You know, and there are other kind of opportunities for how one can do that, but it's critical that registrars anywhere in the country. And remember, sometimes historically advantaged universities may have particular departments that for different reasons are weaker as well. We need all our registrars to get the kind of learning opportunity that's going to make them successful in the exams. Remember, from the CMSA perspective, you know, sometimes people think that we're not on the candidate side, you know. I mean, from our perspective, we're a not-for-profit organization. We're not trying to make more money out of having people do the exams many times. We have a commitment to the country. We are there the public interest, if you like, to enhance the health system, to increase the number of specialists. We have a national shortage. And therefore, everything we can do to assist registrars to be successful quicker means that there will be more opportunities for others to become specialists, and that we increase the opportunities for our people to get access to specialist care. So we're not a business trying to make more money out of things. We're a not-for-profit public interest body that wants to improve the health system and give more South Africans access to specialist health care. And we're committed to doing everything we can to help achieve that. The CMSA, by the way, the MOI, the Memorandum of Incorporation of the CMSA, is not as an examination body. It's to enhance standards of medical and dental care, ethics, quality, access. That's what we stand for. The examinations, we spend a lot of our time and effort on examinations and a lot of effort to make those fair and quality examinations, but that's not all we're about. And part of what we're about is to enhance the registrar learning experience. We are starting to put in place an education platform as well, that over time will build up, and registrars will be able to access that. And so we hope that we'll, for example, have an online learning platform for psychiatry registrars where contributions will be made from psychiatrists around all the academic institutions, and everyone will be able to access that. So I think that we are very committed to this goal.
Thanks, Prof. I think perhaps just to touch on this question about whether or not the least resource institutions will also be brought on par. I think that, with the advent of digitization, there's more opportunities for the sharing of knowledge, right? There's more opportunities for registrars from one university to join perhaps a journal club from another university. And so I think as much as yes, we would like the CMSA to carry people along, but as registrars, I think there's certain things that we ourselves can do in terms of talking with others, figuring out when their meetings are, and just simply asking if we can log on to their meeting. I think all we need is a stable internet connection, and we can move forward. So I'll be moving on to the next question, and that is from Dr. Yo Young. I'm sorry if I mispronounced it. With the rollout of WBAs prolonged and staged, I'm concerned that the end of training assessments are not adequate, as there now are no clinical exam without a thorough WBA type assessment to augment digital exams. I'm not sure if any, I don't fully understand it. I'll repeat it, and then hopefully one of the panelists understands. Okay, so Prof. Green-Thompson, I think you seem to have an answer. You can come in.
I mean, what I'm hearing Matt Young asking is that I think he's worried about the quality of the exit product if we change one thing without the other. And I think we're very mindful that part of an assessment is that you ensure that the public can still trust what you're doing and that the profession can still trust what you're doing. So the idea here is that there would have to be a phased process coming in. So essentially what I'm envisaging, and we haven't come to that absolutely yet, is that we conceivably say year 1 and 2 registrars from 2025 onwards will enter a WBA process. We want to do a modified process in the current system where there's an online exam at the end. But I remain concerned that we think that what we're assessing from a clinical case at the end is a reflection of the person's capacity to practice as a safe specialist. If on that day they do the procedure wrong that you're asking them about, does it mean they can't do it? So what we use that end exam for is really quite important. And maybe some of the things, Matt, is that we say that as you head towards your senior years, your workplace-based assessment contains some observations by people who are not your regular working supervisors. But those are the things, I mean, I'm hearing the concern in your question. I think we've become used to an exam that's run in a particular way, and we worry that it changes the standard or something changes because we're not doing that thing anymore. I want to argue that provided what's coming in its place gives us better guarantees of the product, I think we'll be okay. Thanks.
You answered that really well. Thanks, Prof. Next will be Dr. Sitole, and this appears to be the last question we have for the evening. So if the assessment is not going to be formal as alluded by Prof, how is it different from the current assessment done at the end of the block through the logbook? So if it's going to be an informal assessment, how is it going to be different from what is currently done? I think my understanding is that we're actually moving to a more formal method of assessment. I remember we were talking about how a lot of times people give you an opinion either during the ward round as to how you did something and whether or not you did something well. And now the point is that they're actually going to formalize it to say, I truly felt that I can trust Sharon to do this, or I don't believe Sharon can do this. So we're now moving on from this opinion, more subjective, to what everyone agrees on should be done by the specialist, and that should be recorded. Prof. Bridge?
Excellent synthesis. That's exactly the point.
Yeah. Yeah, and I mean, I think that the issue is that a logbook says you've done something. A workplace-based assessment says you are competent at doing it. And there's a difference between the two. So it lifts the level of assessment and it says to you, it's not just that you happen to do it because you've done 10 of them. It says you are competent at doing it. And it assesses your competence, not whether or not you just did it.
And I think what the EPA does, it adds that level of, we know you're competent to do that. We also trust that you can cover all the bases in that competency. So it's a kind of expanded competence rather than just saying we know you can do the skill.
And I think just, as we're about to close and make some closing remarks, one thing that I've quite enjoyed is the fact that we're emphasizing the professional aspect as well, like the attitudes aspect, the empathy aspect, being punctual, having good work ethic. I think those are things that haven't previously been really measured, but they're still important components of a doctor and a specialist. And it's good to see that coming to light. So as we close, I think I'll just give every panelist maybe an opportunity to quickly maybe just give a final sentence or two, just to close us off.
Sharon, I just want to follow on from what you've said. There was a recent study done where consultants were asked what they valued most about interns. It's a very, very interesting paper to read because it actually talks about being punctual, being professional, being polite, being kind, being humble, being honest about what you don't know about, and doing the work that you're asked to do without having to be supervised. It turned out that your qualification, which was assumed to be present, and your knowledge, which was assumed to be present, and your skills, which were assumed to be present, was part of the deal. What really made a difference was how you behaved. And I think this is the issue that we've been missing all along. And it's such an important part of being a doctor and being a healthcare professional in South Africa. So I really endorse the last bit of what you were saying. Thanks.
Thanks, Prof. Prof. Buch?
Yeah. I think from my side, I think we've really covered the ground of WBA. I think just from the broader CMSA perspective, thank you very much for inviting us. As I've said to you many times, Dr. Harbour, we're available, we're accessible, we're a communicating organization, we're ready to engage and answer questions. And I think we've made a lot of progress. We're making good progress now on WBA as we're evolving to the pilots and its full implementation. But I think that our exams are ever more structured, marked against memoranda. We're removing bias and unconscious bias. The quality of exams are there. And I'm pleased to tell you we're getting far, far fewer complaints from candidates about the exams. Our complaints database has shrunk, and also candidates are feeling they're getting much better service from us, so if you are picking up problems and concerns, either yourself or any of the others on the platform, coming through yourselves or directly, we are available, and we're happy to sit down with you and to learn and listen. If you've got suggestions for improvements, in what we do and how we do it, we're ready and always ready to talk and to hear and to listen and to learn and to make changes. Thanks. So thanks very much for inviting us.
Thank you so much, Prof. And Prof. Green-Thompson?
I want to just say that I'm really grateful for the time. And if you create more spaces in which questions can be answered, I think we're happy to do that. And maybe you collate a set of questions every now and again and send them through, and we can respond to them either on recordings or in writing. Because I think the conversations are important. I think that we would rather you got the support from the source, that we were absolutely honest with you. The things we're struggling with are not different to the things you're struggling with. But so this is the biggest change that we're anticipating in specialist training that the country has seen probably for 3 decades. And I've been involved in undergraduate changes for the last 20 years now. And all I'm saying is that these kinds of conversations are at the very cutting edge of how we manage this change. And are we afraid, a little bit afraid? Of course we are. Nobody changes anything with a little bit of trepidation. But do we stand here in preparation to protect the registrars from a bumpy ride? That's our commitment. And the more we have these exchanges of listening and talking, the better we think we can prepare the registrar's road into this new paradigm. But I do know that if we get this right, we will have a new cohort of specialists that are better than we are. I have no doubt of that. So thanks very much for this time.
Thank you so much, Prof. You make me wish I was specializing at a different time after WBA. Prof. Buch, Prof. Birch, Prof. Green-Thompson, thank you so much for your time. I really, really appreciate it. And I think as registrars, it's nice to know that we're carried along for the ride instead of something just being imposed on us. And it seems like you're listening and you want us to engage. And so thank you for, I guess, valuing our opinion and also being a part of this space where we can share how we feel and our concerns. And to the registrars, between calls, between studying, between supervisors and families, thank you so much for making the time and for, I guess, taking ownership of your own learning and your own future and for being a part of this conversation. I think that, as medics, we're so focused on, being the best doctor that you can be. But I think that these conversations are also important because they impact how you will practice and they impact your patient care. So it's important that we have more of these conversations. And I think from wherever you saw, if you contact anyone at SAMA, they'll give you my email address, or even if you make a comment in the survey that's been posted, they'll give you my email address. I may not respond in 24 hours, but I will respond. But please continue engaging. We want to talk. We want to hear what your thoughts are with regards to WBA or anything else for that matter. I think we're here to represent you. And I'm hoping that what you took from this was not only WBA, but that it was a shift in your opinion of the CMSA, because I know many registrars are like CMSA versus us, and it doesn't necessarily have to be adversarial. I think we can work together. Like ultimately, we all want better healthcare for all, and I think we can all work together to achieve that. So thank you, everyone. I'd like to thank the SAMA Head Office, the SAMA Chair and the Vice Chair, and everyone who has just made this evening possible. Thank you so much. Have a good evening.